a quick review, the pharmacology of the vasodilators and the treatment of angina pectoris. Calcium channel blockers. They are blocking the entry of the calcium from entering the arterial vascular smooth muscle. Here we have arterial vascular smooth muscle. We're enlarging the smooth muscle here, vascular smooth muscle. So normally we have a calcium channel. The calcium will be in. Now that will be increasing the interaction between the actin and myosin and will be produce a contraction. If we block these calcium channels by the calcium channel blockers, then we are preventing the entry of calcium and producing a relaxation in the smooth muscle. So by that it will be producing vasodilatation because we are increasing now the diameter of these small arteries, which responsible about the peripheral vascular resistance. So that will be leading to a decrease in the peripheral vascular resistance. Here we have a different drugs. They ending with dipine, nifedipine, nicardipine. Nicardipine is giving an IV in the emergency situation. Amlodipine and felodipine. Those who are ending with dipine, they are more specific for the smooth muscle in the small arteries, vascular smooth muscle. We have another drug, diltiazem. Now this drug is working both in the smooth muscle of the arteries and also in the heart. And verapamil, this one is more specific for the calcium channels in the heart. So it will be working through the SA node and AV node. So these two medications, by blocking the calcium channels in the heart, they are going to decrease the cardiac activity. And that will be leading to a decreasing in the stroke volume and in the heart rate, which will be ending with a decreasing in the cardiac output. So now, if we are decreasing the peripheral vascular resistance and the cardiac output, that is going to decrease the arterial blood pressure. In the previous slides, we have seen that how the calcium entrance inside the smooth muscle cell will be leading to a contraction. So utilization of calcium channel blockers, which will block the entrance of the calcium in the smooth muscle cells, will be leading to a relaxation. So the use of these calcium channel blockers will be leading to a decrease in the peripheral vascular resistance, as we have seen. Also will be leading to a decrease in the contractility of the myocardium. Besides that, they are going to decrease the arterial and the intraventricular pressure. Also, they will be decreasing the left ventricular wall stress, and also they are going to decrease the heart rate. And for an example, verapamil also will be leading to a decrease in the conduction velocity through the AV node. So all that will be leading to a decrease in the oxygen demand and improving the oxygen supply, because they are going to increase the diameter of the coronary arteries. So they are going to produce then a beneficial effect in the management of angina. Calcium channel blockers producing some side effects like dizziness. It can be understood by decreasing the blood pressure. Constipation, because they are producing relaxation in the smooth muscle of the GI tract. The swelling in the feet and legs, because again they are producing relaxation in the smooth muscle of the blood vessel, so the fluid will be accumulate and then it will be leaking out of the blood vessel to the tissue and producing a swelling effect. Increase appetite. The GERD, because again they are producing a relaxation in the smooth muscle of the sphincters, so it will not be able to maintain the enough pressure to prevent the return back of the acid to the esophagus. Tenderness or bleeding of the gums, very similar to gingival hyperplasia. And finally, we have a sexual dysfunction, mainly in males. In the previous slide, we already explained how the nitric oxide will be leading to a relaxation in the vascular smooth muscle. Now we have two groups. We have nitrates and we have nitrates. As you can see it here, the nitrate containing the nitrogen is attached to 2 oxygen, and the nitrate, the nitrogen is attached to 3 oxygen. Now I'm going to describe whenever these compounds they are inside the vascular smooth muscle by the activity of a specific mitochondrial aldehyde dehydrogenase type 2 is going to be releasing the nitric oxide, and then nitric oxide will be leading to the relaxation in the vascular smooth muscle. Now in this slide I'm going just to mention a little bit about the nitrates, or what they call it, the peppers, because they are yellow liquids and usually will be taken by inhalation. The effect, it will be immediate one, but only will be lasting for only few minutes. And since they are going to increase blood flow to the heart, and that's here. Originally they were used in the management of angina, but now it's not being used, just they are using now as an abuse substances to produce some kind of a high, and also they said that it might be improving the sexual experience. So that's it. Now those who are nitrates, it should not be used as an inhalational agent to manage the angina. So that's it. So now the major one that being used in the management in angina is the nitrates, and that's the one I'm going to explain it in the next slide. The nitrates, I'm going to mention 3 medication. The nitroglycerin, as you can see here, we have a trinitro, 3 of them, and we have here the glycerin. So we have a different dosage form, translingual as spray, and capsule extended release orally, So we have a different dosage form. One of them, for an example, ointment. Ointment either as to be used transdermal in the management of angina, or to be applied rectally, and that's only to treat the pain in the chronic anal fissure. Or it is available also as a sublingual or transdermal patch, and also available as a solution for IV whenever we have a treatment of severe hypertension or an emergency situation, or again as a solution as a translingual. Besides that, we have a tablet for a sublingual administration. Now we have isosorbide dinitrate. Here you can see that we have two of these nitro group, and this only available to be as an oral, to be given as an oral administration, as a tablet or a capsule. And the last one, we have isosorbide mononitrate, and that's also available to be given orally only as a tablet. Now, the major problem, as we will see with these nitrates, to produce a tolerance. So that's the reason here you can see for the transdermal batch, we should be using it for 12 hours and then free of batch for another 12 hours to prevent the tolerance. However, you can see it here that the nitrate tolerance will not develop with the sublingual or translingual products. And this is an important information to know about the nitrates. So the nitrate will be producing a relaxation in both arteries and veins, but more it will be in veins, so they are going to decrease then the blood return to the heart. And that's what we mean by they are going to decrease the preload. By producing also vasodilatation in the arteries, they are going to decrease the peripheral vascular resistance, and that will be what we call it decreasing the afterload. Also, this medication will be increasing the diameter of the coronary arteries and also will be increasing the collateral blood flow. So by decreasing the preload and decreasing the afterload, that it means that they are going to decrease the oxygen demand. And by dilating the coronary arteries and increasing the collateral blood flow, this means that they are increasing the oxygen supply. So that will be leading to an improvement in the oxygen supply demand balance in the heart. Now, the acute adverse effects for this medication can be predicted. The orthostatic hypotension, because they are collecting the blood or accumulating the blood in the veins, the peripheral veins. Also, they are going to produce tachycardia. It will be slight increase in the heart rate as a compensatory mechanism for the drop in the blood pressure for the hypotension. And also they are going to produce headache. The headache here, we have two types. I'm going to mention it. So we have, first of all, we have the immediate one. The immediate headache that it's actually related to the vasodilatation effects that will be produced by this medication and will be happening in the first hour of using this medication. Usually it will be mild in severity without characteristic symptoms of migraine as the second one that I'm going to mention it, and usually it will be ease spontaneously. The second type, it is a delay one, that will be usually a moderate or severe. It's very looks like a migraine type headaches, and usually will be developed about like 3 to 6 hours after the intake of the nitrate, and will be last longer for a longer period of time, will be also accompanied by symptoms like nausea, vomiting, photo or phonophobia, and it will be triggered by the release of specific substances like, for an example, glutamate, or the change in the ion channels function that will be produced by the activity of cyclic guanosine monophosphate. Now, one of the major issues in the using of this medication is developing the tolerance, which will be developed very rapidly. The development of tolerance, it may be related to different factors, probably retention of salt and water, and it will be not a major issue, but probably the major mechanism for developing the tolerance is the depletion of the tissue sulfonyl group, SH group, or because they are having a scavenging of the nitric oxide by superoxide anion. And that will be leading to a production of peroxynitrite. The production of peroxynitrite will be leading to inhibition of the guanylate cyclase. And by inhibiting the guanylyl cyclase enzyme, then the activity of this agent, it will be lost. Now let me remind you about the rules of the sodium current with the generation of the action potential. In the beginning, we have opening about 99% of the sodium channels that are present in the cell membrane for the cardiac cells. It will be open, so the sodium will be rush, and will be just their opening will be continue for about just like 1 to 3 milliseconds until we'll be reaching a peak, and that will be responsible about the phase 0 from the action potential. Now, less than 1% of the sodium channels which had been inactivated will be able to move from inactivation to the open state, and that will be responsible about the late sodium current, and that will be producing part of the responsible about part of the action potential 1 to 3. Now, however, in some condition, these less than 1% of the sodium channels probably will be going into a rapid inactivation and activation, opening and closing. So that will be responsible about the production of the late sodium current. And the late sodium current here, it will be leading to a change in the concentration of the calcium inside these cells, and that will be leading to a specific twitch or contraction. The contraction here, as you can see, it composed of a basic and a tonic component. So here I am drawing a cardiac cells, and in the cell membrane I am drawing just like 1 sodium channels. As we said that in the late current of the sodium channels, we have sodium will be entering through these channels, which will be moving from the inactivation to the open state. And that's here we have an exchanger between sodium and calcium. So whenever the sodium will be in, it's going to be taken out of the cardiac cells in an exchange with calcium. So we are going to increase now the calcium inside the cells. Now, in these sodium channels, normally we said it's supposed to be inactivated. However, in some condition in myocardial ischemia, the inactivation mechanism for these sodium channels, it will be impaired. So we still have then these sodium channels. They are able to move from the closed state to the open state. So they are going to let more sodium to enter. Then we have more sodium will be out in an exchange for more calcium to be in. So that will be leading to an increasing the calcium overload, and that will be definitely leading to an increase in the diastolic tension, in the contractility of these myocytes, and also will be leading to increase the work. So here we have the drug ranolazine. This drug is going to accelerate. This one of the mechanisms they said it may be the responsible about its activity. It's going to accelerate the inactivation of the sodium channels, and specifically for those who are working as a late sodium current. So by this way, we don't have now an entering of the sodium. We don't have an exchange with calcium. So that will be leading to decreasing the calcium overload and will be decreasing then the diastolic tension and the contractility and work. So by this way, it will be effective in managing specific cases of angina. This drug has little or almost no clinical effects upon the heart rate or blood pressure, will not be decreasing the blood pressure or will not be affecting the heart rate, will not also be decreasing the heart rate. This medication will be given orally, 500 milligram twice daily. You can increase it after 2-3 weeks up to a maximum 1000 milligram twice daily. Some of the toxicity or side effects is going to produce QT interval prolongation. Also, it will be leading to some nausea and constipation. And also, it might be leading to a dizziness.